Well, now we go straight on to the final session of you as a gathering before your final plenary after lunch. And leadership to achieve the impossible. If I asked you as mental health leaders and advocates and professionals, activists, fighters, survivors, what one problem in the mental health sector feels absolutely intractable, too important not to get right, but too difficult to achieve a solution to, what would it be? Yell some out. One person, yell. Stigma. What else? Workforce. What else? Resource imbalance. What else? What was that? Compulsory detention. People who quit but don't bother to resign. Wow. They just quit, but they're still there. Failing. Wow. Promotion. Coercion. The opposite. Culture. Which could work in so many directions. Prevention. Compassion. Dignity. Egos. Hope. What else? Competition. Power imbalance. Bad outcomes. Not listening. Suicide. Two of the themes that are going to be discussed next have come up in this room, and it's hard being leaders, isn't it? All these things you're grappling with. Two themes: suicide, seclusion and restraint. And our two presenters are going to consider these two big, raw, real, ever vibrant challenges in people's lives. And I wanted to quickly read a comment that I received when I looked at the issue of seclusion and restraint on a program. It was from, I won't name them. I have worked for over 5 years in an acute mental health unit. Seclusion is a very last resort and has to be ordered by a psychiatrist. Chemical restraint is also a last resort. Many an OT or social worker who is vehemently against seclusion has claimed there are other ways to de-escalate a patient without ever being in a locked ward with a psychotic patient themselves. I have been assaulted more than once, have seen a colleague badly bashed more than once by the same patient, and I've seen other patients assaulted. I have also seen a sink and a fridge ripped off the wall, chairs smashed and thrown against glass panels and walls, glass panels punched. These are difficult words, I acknowledge this. Doors rammed and slammed very hard. It's easy to dismiss seclusion as a draconian punishment rather than a safe and quiet option for a distressed person when when you do not work in this environment and with patients for 8 hours of the day. I have seen patients go in distressed and come out calmly without the need for chemical intervention. I've also seen patients go into seclusion voluntarily as they find the experience calming for them. Difficult words, I acknowledge this, and triggers in some cases. So I just share this because it felt to me that it expresses the complexities from one perspective. There are many admissions now due to drug-induced psychosis where the patient is paranoid, distressed and out of control physically and risk the safety of themselves and others. Seclusion should by no means should be abused, but I feel it still has a place in psych nursing to protect the safety of the patient and others. Those who don't agree should walk in our shoes. And one final comment. Karen, as someone who has supported individuals who have mental illness and have been placed in seclusion, it appears the experience only adds to the already evident trauma the individual is experiencing. In fact, appears to fracture their mind even more so, and I would suggest to a point of creating a broken mind. Self-harm in the form of headbanging have been the consequences from what I've witnessed. Dark ages treatment. So I got a lot of comments, and people felt that I was, at the time when we covered it, too sympathetic to the push against seclusion. So I was very affected by the comments that we received, and I'd like to use that as a way of introducing these two speakers. We have, first up, Peggy Brown, and then we're going to have David Covington. Peggy, Dr Peggy Brown, is Chief Executive Officer of the National Mental Health Commission. During a career spanning over 30 years, Peggy's held a wide range of clinical and admin positions in Australia, the UK. She's been Chief Psychiatrist, Director of Mental Health in Queensland, in ACT, Northern Territory, 5 years as the Director General of ACT Health. Many other roles. Please read her biography in your program. But she is here to present to you about seclusion seclusion and restraint, beg your pardon. And then we'll hear from David Covington, and then we'll bring you all together to talk to them both. Thank you. Please welcome Peggy.
Good morning, everyone, and thank you very much for the invitation. I've been asked to speak relatively briefly in relation to my experience leading the National Seclusion and Restraint Project, which in fact goes back a decade or so now. So I'm certainly not going to speak at any great length, and I hope I can do it justice in the brief amount of time that I've got. But just to start with a quote, I always like someone to have wise words at the beginning in case the rest of what I say is absolute rubbish. But a quote: "Forget about all the reasons why something may not work. You only need to find one good reason why it will." And if we're talking about focusing on reducing the use of seclusion and restraint, indeed seeking to eliminate the use of seclusion and restraint, then I think we do have a very good reason. It's not therapeutic. There is absolutely no evidence base that would suggest that either seclusion or restraint are therapeutic. And in fact, quite the opposite. We know that they do harm. They do harm in many different ways: physical harm during the events, emotional and psychological harm. And that's not just for those on the receiving end, it's for staff who might be delivering this particular intervention. So this was recognised back in 2005. The Safety and Quality Partnership Subcommittee of the Mental Health Standing Committee actually undertook a consultative process and went out and asked, what are the key issues around improving the safety of mental health services? And from that developed a document. Now, the document didn't list everything that came out of the consultation, but it highlighted 4 key areas. They were suicide prevention, reducing seclusion and restraint, impacting on medication use to reduce the harms there, and on safe transportation, which in Australia is a significant issue. So reducing and, where possible, eliminating the use of seclusion and restraint was one of those 4 safety priorities that was identified. And it was good to identify it, but it's then, what on earth do we do about it? How do we start to tackle this in any sort of a national coherent way? And we were very fortunate in 2005 that we had Bob Glover from NASPID come over as part of a IIMHL match. And he came to Canberra and he told us about the work that was happening in the States. And so from that, the National Seclusion and Restraint Project was formulated. And we were informed in terms of how we approached this by the framework that had been developed out of NASPID with Kevin Ann Huckshorn and her colleagues. They used what they called their 6 core strategies framework. And that was about leadership, but leadership particularly looking at how you change organisations and culture. It was about using data, about developing the workforce capability and capacity, about using tools to assist to prevent the use of seclusion and restraint, about particularly developing roles for consumers to inform how this actually is rolled out, and also debriefing techniques. And so what did we do in Australia? Well, we had funding from the Australian government, which was for 2 years. Now, that's an incredibly short time frame in which to even contemplate doing something. But what we rolled out were these key 6 measures. The first was the Beacon Demonstration Project. So we gave a small amount of funding to 11 sites across Australia, sites that had volunteered saying they wanted to participate and be a beacon site. And they adopted the 6 core strategies framework, and we brought them together on a regular basis, and that became the start of the National Seclusion Forums. And they went and took this approach in their own individual services, and were there then, I guess, a demonstration site. And they could tell you what worked and what wasn't working. And there was some great sharing coming from that. That was assisted by some international study tours, going to places in the US and the UK in particular, where they had virtually eliminated the use of seclusion and restraint. We started some work around national definitions and principles and procedures. Australia being a federation of states and territories, of course everybody had a different definition and a different way of approaching the problem. We also started looking at the issue of how do you collect data and how do you actually report on seclusion, because it just wasn't collected or reported in any public way before. We also looked at education for the workforce and how we could actually build that in. And we tried to develop a community of practice so that those beacon sites and any others who wanted to participate and share, we could do that sort of digitally. I have to say that was probably the least successful of our endeavours. I have to say that in terms of the challenges, I think there were many, particularly challenging that, the way we do things. We've always done it that way, and that organisational culture. It takes a lot of courage to step outside the long, deep-rooted history of how we do things and say, actually, we need to do it differently. And I think there was a lot of courage in the beacon demonstration sites. There was also a lot of courage from consumers and carers who stood up and said, actually, this is really important. We demand that you do it differently. I think one of the quotes Natasha gave earlier, I think, demonstrated the issue of the fear that comes when you have staff who go to work to do a good job and are faced with incredibly challenging situations. And they don't wish to get harmed, they don't wish to harm anyone, but sometimes they're not sure what else to do. And in the face of that, undoubtedly the industrial issues come to the fore, and so we found ourselves engaging with unions as part of this. Interestingly, medical staff were probably the hardest to engage in the whole process, and I'm not sure what that's about. There was questions about legislation, and should legislation be changed to make it actually more, regulated in terms of, or legislation in terms of when and how you can use seclusion and restraint. There were questions about the design of units, and should we actually eliminate seclusion rooms and seclusion suites in units. Certainly getting data into the public domain around the use of seclusion restraint, very challenging, and this debate went on for some years after the conclusion of the 2-year project before data was actually published here in Australia from each of the states and territories. And for us, I guess the biggest challenge was we only had 2 years, and 2 years is not enough to embed any lasting change. In terms of what I think did work or helped, I think having real clarity in terms of what it was that you were aiming to achieve, and not only what, but why why it matters to make this change, why it matters to overcome the challenges. I think leadership is part of that. Partnering with consumers, to my mind, was the absolute key. I think without that consumer voice, this would have been so much more difficult, and I think it was essential. I think putting the focus on safety and quality and not on judgment and blame about services that did use it was an important foundational step. I think having objective measures to judge how we're going and sustaining our focus was important. For myself, at the time when I led this project, I was the Director of Mental Health in ACT, and I firmly believed in what we were attempting to do. But let me tell you, I had my doubts about whether I could affect change in my own service, just knowing the challenges I had there in other ways. And we took all of the steps that we kind of outlined, I guess, in the framework approach. We certainly had leadership and we had commitment. We tried a top-down and a bottom-up approach. We were participants in the national forum. We had our change champions. We orientated our staff to a new way of working. We made significant environmental changes just in the ward setting. We changed the way we approached when consumers came into the ward and engaged in dialogue with them about their triggers and about what would help them to self-soothe and settle and de-escalate. We used data undoubtedly, but the things that made, well, the thing I think that made the biggest difference was our consumer engagement. And particularly, and I'll pay credit here to Bradley Fox-Lewin, who would be known to some of you. Bradley actually came in and he worked with our staff and we implemented a seclusion review process. So every episode of seclusion was reviewed in a multidisciplinary forum with Bradley leading the discussion, and not in any sort of a confrontational or accusational way, working through with staff what happened, how it could have actually been seen from different eyes. And it actually changed people's appreciation, not just their knowledge, but their understanding. And Bradley then went on to do some consumer-led research, which he's published and I think is often referred to. But we were very successful in the ACT in actually reducing our seclusion rates down to not quite zero, but to very low levels. And in terms of beyond the 2 years of the National Seclusion Project, as I said, 2 years was never going to be enough to actually embed lasting change. The Safety and Quality Partnership Subcommittee has endeavoured to keep a focus on the use of seclusion and is now extending their work into the area of restraint. And the annual forum around focusing, and it's now called the Restrictive Practices Forum, but that has sustained, and I think this year it's in May in Western Australia, and I think that's the 11th forum. The Mental Health Information Strategy Subcommittee has taken up the challenge of collecting and analysing and reporting the data in association with the Australian Institute of Health and Welfare. And so we have now seen a couple of years of jurisdictional data actually reported. The National Mental Health Consumer and Carer Forum has maintained their activity in this space. They put out a statement, and the National Mental Health Commission has also endeavoured to maintain a focus on this and has had a project and a declaration about it, and continues to do some research to inform about best practices and ways of challenging culture and changing the experience. So look, that's probably all I want to say just to kick us off. But to finish with two things. What have I taken out of this experience? I think this says it all. Don't limit your challenges because they're too difficult, because they're too scary, because everyone says, no, we can't do that. You really need to challenge your limits. And if you think something is important, if you believe it is important, then you can and must work to change it. Thank you.
Peggy. Thank you, Dr Peggy Brown, and that will give you cause, prompt discussion, I have no doubt, after David. I found, Peggy sent me the 6 core strategies for reducing seclusion and restraint use document, and as I was reading it, I found myself tweeting it, because it's a very interesting read. Some of you might have read that document. It comes out of the National Association of State Mental Health Program Directors, and it actually got me thinking about leadership in all sorts of settings as I was reading it, and how you kind of build a sense of collegial responsibility for change, understanding the anxieties and fears and history that people bring to a conversation about changing a practice. So I actually found that very, very good read. David Covington serves as CEO and President of RI International. Is a partner of Behavioural Health Link, and he leads initiatives like Crisis Now and Zero Suicide. It's zero suicide that David's going to talk to you about today, and pose a challenge to you, as he has been around the world. And of course, David's just co-hosted the 3rd International Summit of Zero Suicide in Healthcare here in Sydney. Actually, who was that? Who was at that? Pop a shower of hands up. Okay, so that's great. There's a little bit of continuity in the room. He previously served as Vice President at, is it Magellan Health, responsible for the executive and clinical operations of the $750 million per year health plan contract with Arizona Medicaid and the Department of Health Services. So he gets stuff done, and he would like to challenge you with the zero suicide concept as well today. Thank you. Please welcome David to Australia and to your stage.
Thank you so much, and I'm going to start with a question. How big is your dream? How many of you are familiar with the BHAG concept of leadership guru and business author Jim Collins? So a BHAG is a big, hairy, audacious goal. And he came up with this concept in studying the world's top performing companies. As he looked for what united them, he found that they galvanized their efforts, they inspired their teams and their organizations, and they got stuff done by developing these audacious, big, hairy goals. Now, about 8 years ago, Jim Collins was approached by a man named Tommy Caldwell. And Tommy said, Jim, what if your BHAG is unattainable? Now, Jim had not heard that question before, but Tommy wanted to climb the Dawn Wall. The Dawn Wall is a portion of El Capitan, a sheer rock cliff face that's known for its extreme pitch and its lack of vertical cracks. Now, the vertical cracks are important because that's what the climbers put their hands and feet in to make their way up. And this wall was thought to be unclimbable. It could not be done. And so Tommy asked Jim what he thought about that, and Jim didn't know how to answer. He said, well, here's what I do know. If you're sure on the front end of the process that your BHAG is attainable, then it's not a BHAG. So that's where it started. And Tommy and his partner spent 7 years mapping, planning, preparing, and failing. They failed 5 times to ascend this summit. Ultimately, just over a year ago now, he and his partner spent 19 days on this wall, and they made it to the summit. Now, I think when we hear stories like this, it's just impossible for us to capture how challenging that goal seemed when they set out to do it. We kind of have a ho-hum, when something has been achieved as opposed to when we start. Now, Jim Collins told this story at a healthcare conference I was at about a year ago, and healthcare leaders there began thinking about the BHAGs that healthcare has taken on. In the 50s, there were 50 million cases of smallpox per year. But the World Health Organization began to at least think maybe advances in vaccination could lead to some change. And it's been almost 40 years since we had our last naturally occurring case of smallpox. So relative to smallpox, we are at the top. We've ascended and stand on the summit. What about polio? Polio, there were nearly 400,000 cases a year in the 70s, and this seemed like something that we could not eradicate from this planet. But somebody, again, set a BHAG. And where are we at with polio? We're very near the summit. We have 3 nations left where it still exists. So we're close. Now, other things, we're climbing that wall. HIV and AIDS, there was a time when we did not understand it. We were fearful. It was usually fatal. Where are we at on that wall now? The World Health Organization set a very audacious goal, and this past year they say they're on pace. We reached the summit globally and have reduced the rate by 25%. So they're on the wall. They are climbing the wall. Where are we at with suicide? Have we determined to climb the wall? Now, this particular graph shows a number of other diseases. The bottom line is we have learned that organizations, healthcare, other industries, anything we put our effort and resources to, no matter how intractable it seems, we make progress. Here you're looking at from the peak, and for the various diseases between 65 and 95, you see the height, whether it's strokes, leukemia, heart disease, HIV or AIDS. Every single one of those, we have global efforts to challenge them. We are climbing the wall, and we are steadily making progress. We are learning, we're putting all kinds of effort into it, and we are moving, with one exception. The question is whether we're not making progress with suicide because it's different or because we've not determined to climb the wall yet. Have we, as a globe or any one of our individual nations, can we say that we've even dabbled in suicide prevention? It's not to say that there aren't many individuals making heroic efforts, but in the terms of the broader context of the resources, and in particular in the healthcare environment. Now, Forbes magazine in 2010 had this as a graphic in their article, The Forgotten Patient. And it was a criticism of the entire healthcare industry in the U.S. Commercial sector, public sector, research, pharmacology. And it basically said that if you bring a host of issues, trauma, depression, anxiety, addiction, grief, if you bring that to the healthcare environment, there's a loving light of best practice and evidence and approach climbing the wall in all of those areas. But if you mention the S word, you are relegated not out of the system, but as far to the periphery as you can possibly go. That the resources of these organizations, the training, the support is not there for suicide. Now, when I was at Magellan Health, we actually did a survey. We had about 10,000 in the workforce that worked in a number of agencies in the Phoenix, Arizona market. Ultimately, we landed up doing the survey in 9 states, and over 30,000 in the behavioral health care workforce took part in the survey. Clinicians, social workers, psychiatric nurses. Basic questions. Do you have the skills, the support, and the training to engage those at risk of suicide? Didn't say, could you save lives? Were you just prepared? Can you just agree? 50% said they could not agree to those 3. So in the U.S., we have a system where gatekeeper training and identification is designed to get people at risk more effectively to the mental health system, where, what if you have been to the medical, how many of you have been in for some kind of medical procedure in the last 5 years? What if your physician had said, I don't have the training for this, no support from the organization, and I don't have the skills, but let's go at it together. I'm all in. The reality is that's not what they say. They actually are trying to get the person out of their office. Now, a lot of people see this as a liability concern. What the surveys show that it's more in the gut. I'm afraid I'll harm them. I don't know what to do. I'm afraid. Let them go to somebody that can help them. These are just a sampling of the comments that people have made in the survey. I'll just pick on the one in the lower right because this came up relatively frequently. I think suicide is in our communities, but I do not, all caps, think we should be spending tax dollars to do anything, all caps, about it. What's underlying that? Well, it's basically the one in the upper left. If people are serious about it, they will complete it no matter what is done for them. That's neither based in science, nor does it pair with the lived experience of people who are talking about this with us now. The other thing we learned in terms of the baseline of where we're at now is most of our efforts in the U.S. and in other countries sometimes as well are on certain high-risk groups, older white males, certain indigenous populations, LGBT youth, veterans and military, all at escalated risk. All of them are. But you almost have to stack the relative risk of those groups to realize the risk of those with schizophrenia, major depression, bipolar disorder, borderline personality, and certain eating disorders. And yet clinicians have not been trained or prepared or feel like they don't have the support from their organizations. When do we begin climbing the wall? When do we set out that we're going to do something different? Part of the challenge was in 1996, there was a discussion of including suicide more seriously in the DSM-4 TR, the mental health Bible for billing and coding. And it's in there as a subset, a symptom of major depression, et cetera. But we were going to have a much more major discussion of it. But we in the suicide prevention field said, no, don't do that, because this is not a situation like those others. This is a conscious choice of an individual. It's an intentional action, and we shouldn't include it. Wow, that doesn't seem to pair with the tragic agony that people who are experiencing suicidal thoughts describe. So we thought about how do we begin to get folks challenging that wall. What is this? It's a bridge. What bridge is it? That's the Golden Gate Bridge. Now, many of you maybe didn't immediately recognize it, even though you've seen in your lifetimes, especially if you're an American, you've probably seen thousands of pictures of that bridge, but they're typically looking down at that bridge or looking at it from various angles. This is on the bridge and looking up. The telltale sign is the cable up in the fog. You haven't seen this picture because I took it, standing on that bridge, looking up. We decided we had to have a new way of talking about this. We'd have a new narrative, if you will, and we needed a metaphor. And we used the Golden Gate Bridge. The Golden Gate Bridge has actually been a place that has saved many lives. There are crisis phones on the bridge and trained staff who negotiate and support individuals that they identify at risk. It's believed that for every individual who's died there, 2 people have been saved. One way of looking at that is healthcare also has saved many lives and does today, is saving lives. And yet, like the Golden Gate Bridge, we've been a very unsafe place, and many have died. The Golden Gate Bridge ultimately decided in 2006, after the film The Bridge aired, that they would move from it's being a peripheral issue for them, and they had to bring this to the core. They had to have a plastic-coated steel safety net under the entirety of that bridge that would drive suicides to zero for those for whom they were responsible. So in 2010, the National Action Alliance in the United States created a vision for a nation free from the tragedy of suicide. Eduardo and I were in that group. Richard McKeon is here. Several of us in a task force landed up putting together a framework for suicide prevention in healthcare that was inspired by the Henry Ford Health System. And ultimately, it led to an international declaration that was prepared by a group with IIMHL who met in Atlanta prior to the Vancouver conference. And we used a model that Professor Joe Smith from the UK facilitated that had been borrowed from her efforts and David Shears and others around early intervention services for first break psychosis 15 years earlier, when that was totally unheard of. And they were inspired in turn by the International Declaration approach that had been used by healthcare leaders 10 years before them, when the co-management of diabetes just was not something that had been thought of because of the lack of advances in technology. So this Zero Suicide International Declaration was our starting point. There's now a zerosuicide.com website supported by the Suicide Prevention Resource Center with a fidelity toolkit and a set of supports, including that organizational survey that I mentioned earlier. And here in Sydney, in partnership with Suicide Prevention Australia and Sue Murray, we had leaders from 15 nations, 70 people gathered together, sponsored by the AMP. There are now about 500 of these initiatives in the U.S. Several of us, Dr. Mike Hogan and I, met with Carolinas Healthcare just a few weeks ago. Carolinas Healthcare is a 900-location, 40 hospital, 60,000 employee, not-for-profit healthcare system. They're looking at adopting and adapting a zero-suicide approach. We've also got several initiatives that are going on in the United Kingdom, in the Netherlands, the Basque public health system in Spain, the Hal Morton Hospital in New Zealand, and we've also got a terrific program that is developing on the Gold Coast here in Australia. So we have seen that human beings, when we put our efforts together and when leadership brings resources to bear, whatever we challenge, whatever we tackle, we make progress. So I'll end with, how big is your dream?
Wonderful, David. Thank you so much.
I just wanted to make a very brief comment in talking with Dr. Brown. I appreciate all of the things that you shared with regards to the national's involvement with the certainly with the efforts that went on then. I just wanted to update folks that the SAMHSA 6 core strategies that were mentioned by Dr. Brown, there has been a number of revisions that have been made. So as you go online and you're looking up the 6 core strategies, also look up under SAMHSA what's called the 6 principles. And these 6 principles are listed because they are more transformation oriented for these services that you work with. And number 1 on the list is safety. We then work with trustworthiness, collaboration, mutuality, peer support, and even looking at historical and cultural issues. This is because SAMHSA, in their infinite wisdom, discovered that in seclusion restraint reduction, that in the US, when you ask people to stop secluding, they did exactly that. They just stopped, which then raised the safety issues in every environment across the nation. So they've now modified their approach to say that we are promoting the reduction or elimination of seclusion restraints through trauma-informed practices.
Thank you very much. Peggy, do you want to add a comment?
I guess what I would say, though, is I think that in any endeavour, we need to avoid a kind of a rigid adherence to some framework, and we need to have in place the process that keeps it real. And for me, that would be that process of having the review of, as I described, every episode of seclusion, what was happening, how's it experienced, what's your data telling you? Have the process where there's the consumer voice, there's also the staff voice, and be prepared to take account of what the experience is and respond to that. Don't just rigidly adhere to a particular framework. But I thank you for the principles, because I'm sure they're very valid.
And Faye Jackson was stating that the key parallel movement here to the seclusion and restraint conversation is the peer worker movement. Because if you have peer workers, and Faye might like to add to this if we want to get a mic to Faye, if you have peer workers working alongside you in the workforce to reduce seclusion and restraint, you have success. Faye?
Yes. Sometimes peer workers are accused of having a one-eyed view and not having knowledge of the front line, what that's really like, and working. Well, you know, most peer workers in the public system do work at the front line and they are aware of what's going on, and I certainly worked at the front line for 4 years and would be involved with people, say, when they were being taken down by security guards, that saying, keep your eyes on me, just trying to keep them safe and keep them in our relationship rather than in what they were experiencing as abuse. And if you went back and found out what happened before, if a peer worker had been brought in before at the very first signs of something going wrong, and often it was about not being listened to, not being heard, being stood outside of the fishbowl for hours while you're trying to get, you know, be able to make a phone call or ask for medication or whatever it is. And the fishbowl stops the relationship, and peer workers build that relationship, and where there's relationship, authentic, true, mutual, reciprocal relationship, then it's very unlikely to have seclusion needed. I do think, though, that that ICE has brought another layer into psych wards now, and I think that's can be really terrorising and certainly not a therapeutic environment.
Yeah.
For anyone in any.
Yes, I almost feel like that's it's affected every kind of context, hasn't it? Healthcare context, certainly in Australia.
Natasha,
David.
A quick comment. I think that those are great, really, reactions. RI International, formerly known as Recovery Innovations, we have a dozen crisis centers across the U.S. in 5 different states, and we don't have any of the plexiglass fishbowls that you're talking about, because it does. It counterintuitively creates challenges as opposed to, the other thing is, out of our 1,000 staff, we have about 500 certified peer support staff. Over 50% of our workforce are individuals who have a lived experience, and we do find exactly what you're talking about, that when an individual comes in, a lot of times in the back of a police patrol car, sometimes shackled, sometimes hands and feet, that them coming in, the very first thing that happens is they're engaging with a peer staff who might have had a similar experience, and that makes a big difference. And this approach that Sam's is talking about, putting safety first and then building that mutuality around it.
Over there, thanks.
Tim Heffernan, I'm a peer support worker in the public mental health system in Wollongong. I think, the BHAG is very much about when will we build the therapeutic environments for us, for people with lived experience, to design and build and live and go to, because I think, the central problem is with the environments that you choose to build for us, which are totally inappropriate for us to heal, for us to stay connected to our family, our loved ones, our jobs, etc. I think if the staff are faced, Peggy, with incredibly challenging situations, at every stage we're faced with incredibly challenging environments and situations, that the police coming to pick you up when you're psychotic, the ambulance trip from Wagga to Goulburn or wherever, where you're stopped and secluded and were restrained by chemicals for the journey. Those sorts of things make it difficult, but I think we're a bit like asylum seekers, so we're going in the reverse. We're going into places as peer support workers to try and affect these environmental changes, and it's very powerful, but I think some of us are feeling, even in this space here today, that we're a little bit subdued and sedated because we are a minority, I think, and it's sometimes hard for us to find our voice, to express that we do feel Faye's address was wonderful and uplifted us, but in some cases we do feel still that our voices are one that is not there all the time, is not there listened to. The idea of partnership, we should be leading it, as Faye said yesterday.
Thank you. Thank you. We have another comment there. All the hands are going up. Oh, there, sorry.
That the safety net did not work in itself all the time because people jumped off the safety net as well, but that they had not fenced in the walkways properly because of the aesthetics. And I'm not sure if they fixed that now, because you just can't do a partial solution in these situations. And I agree with you about the science. The issue I really want to bring up with you is what contribution has gun control got to the zero suicide?
Very interesting question.
As we do a lot of comparison, as the US does with us, about that issue. And the BHAG I would have comes to Peggy, and that is the issue of not just dealing with seclusion and restraint, but coming back to Faye's keynote lecture, the importance of voluntary care and people choosing their care, including their inpatient care, and how to engage people in shared decision making and living wills and all the other technology. We know, we have the evidence that says if we were systematising all these things, we would have much lower levels of involuntary care. The involuntary care rates in English-speaking countries is horrific, and we need to reduce that, and that would be a fantastic goal and BHAG for us all.
Would you like to pick up on that? Actually, before you do that, someone's had his hand up at the back for quite some time. Can I just grab one more comment? Can you hold your thoughts about that? Because we have to wrap, and I'm just keen to capture one more very persistent hand.
Hi, Stuart Gray here from New Zealand. I think when we look at seclusion and the 6 core strategies, I think one of the things that we forget is that the environment that emerged in. Now, the drivers for that were public opinion, basically, because there was a lot of publicity on some of the awful things that were happening in the name of care to especially young people. And that drove some legislative change, which I think then encouraged organisations to get on board. And I suppose my question to the learned people up front is what sort of either social, as in where our media partners may come into play, but what other legislative drivers do you think can assist in reducing these things?
Interesting. So let's come to the gun control question, David.
Yeah. So, let's just talk briefly about the Henry Ford Health System. They became a subject of national conversation when a large hospital health plan system in their behavioral health unit. And in their behavioral health unit were individuals at very high risk of suicide and dying very frequently. They did what we've talked about today. They brought this to the central focus. They put their enterprise resources around it, and in the first 4 years, they saw a 75% reduction in their death rate. Ultimately, a few years later, they had a 10-quarter period with no deaths. And those who saw that data initially, most doubted that it was real. But as you peeled it back, what you found was an organization that did exactly what we're talking about. They realized their workforce lacked training, skills, and support, and they used a suicide-specific treatment to bring training to their workforce. They brought their electronic health record, Epic, to bear in providing clinical supports. They had leadership saying that we were going to create a new environment. And in addition to that, at every visit for those with any risk or discussion of suicide, they were doing collaborative safety planning and evaluating means restriction and means reduction with the family and others, of frequently finding there was a firearm in the home when they didn't know that previously. So it's sort of not as much rocket science as we might think. It's that bridge, putting that barrier up. Actually what we find is you drive the death rates to virtually zero when those measures are put in place. And the science has time and again said that people don't go on in mass to die somewhere else. That 19 out of 20, even when they've made a suicide attempt or been pulled off that bridge, for an example, are going to find some way to cope or going to find some way to thrive if we can support them in the moment. So the healthcare has an opportunity to engage regardless of the culture. In the U.S., certainly firearms is a major driver, but in other cultures it's something else. And healthcare can be a big part of that equation in saving lives when people are at that point of risk.
Yeah. That's right. I think of farmers in India who were drinking pesticide and still are.
Yep.
Peggy, would you like to pick up on the other comment that was made, and also the question of legislation as a driver as well?
Yeah, look, I might kind of start with that because I think I can possibly wrap a couple of those things together. I think legislation has a role, but I personally believe that legislation can't necessarily affect the change. And I think there's a risk in people thinking that, oh, well, we'll just change the Mental Health Act and therefore we'll control the use of seclusion restraint or compulsory care or whatever it is. You and I both know, we all know, that someone can tell you to do something and you might do it while they're watching. You might do it if you think there's going to be some adverse consequence if you don't. Significant consequence. But once they turn their back or the spotlight goes on to something else, you'll probably go back to doing what you've always done and what those around you do. So just saying do it differently isn't going to cut it. And I think it comes to Alan's question about compulsion in care as well. We've used the legislation to compel people around receiving mental health care, but we know that it's not necessarily all that effective. What would be better is if we can engage with people, if we can actually change the understanding, change the nature of the relationships. And I think Faye's comment about peer workers it was absolutely on the mark. That's what's going to affect the change and affect the changing understanding, is when we can see and hear and experience a different way of doing things by understanding the adverse impact we have from our naive kind of big brother type approaches at the moment.
Thank you, Peggy. Final comment from you, David?
Yeah, so my final comment is this issue of lived experience and lived expertise is one that is just profoundly important. Peggy referenced it as a key driver with seclusion restraint. One of the milestones in the zero suicide in healthcare movement was, where's Eduardo? Eduardo Vega organized a summit in San Francisco a couple of years ago now, and it had policymakers and healthcare leaders at a suicide prevention summit like we've had 100 times before. But this is the first time that 60% of the room were individuals with lived experience, people who had made suicide attempts, and we were the minority in the room, to your point. His history before that is, why would you want to get a group of suicidal people in a room together? Only negative things could come out of that. And what occurred instead was just magical. It was like no meeting I've been in before, and the movement has really changed as a result of the intersection and the leadership of individuals who could bring us a view that we lacked in our view over the course of time. I think there's this view that including peers or lived experience or the patient, if you're in a healthcare setting, is something we're supposed to do. And it's like this good thing, virtuous thing to do, when in fact, that in and of itself is this magical thing in creating something different. So I'm thrilled to hear this theme just coming up again and again.
Yeah. Thank you both very much. That was a fantastic session, I think. I hope you agree. David Covington and Peggy Brown, thank you so much. Thank you. And fantastic questions, and I hope you've been taking photos. I'm sure the organisers can follow up. And please, finally, I remember the gifts. Thanks, John, and thank you, Peggy and David. Thank you so much. And nearly lunch, so you can feed yourself. And I, at this point, will say farewell. It's been a privilege to be just a small part of your conversations here, and I hope that it's been an enriching and rewarding meeting, mainly by virtue of the networking opportunities that something like this creates. And may you follow up on some of these conversations via email and this amazing... I wish I'd got one of those, actually, now. I would have been busy interfacing with you all. So thank you very much. I hope it's been rewarding, and it's really lovely to work with you. As you're leaving the room, initially, though, stay for one performance, because this whole event's been informed by creative expression and the arts. And we have a choir, you know, who's using song to process trauma, in a sense. They're an initiative of the Opera Australia, Fairfield Multicultural Health, and starts the New South Wales Service for the Treatment and Rehab of Torture and Trauma Survivors. They are called the Spanish-speaking choir. Many of the choir's members, if you turn around, you will see these gorgeous people dressed beautifully, are drawn from a STARTS support group for South and Central American women. And they are going to perform you a song now before lunch. And then we encourage you to grab your lunch, continue the conversations, and they'll perform while you're enjoying and talking together over lunch in this space as well. So please welcome the Spanish-speaking choir.